It's so nice to see you all this morning. Thank you for coming. I just wanted to give a little bit of background about why we're holding this training this morning, and then I'll let Sharon introduce Dr. Welzant, and we will go from there. So, I don't know, about a year ago, the Public Education and Program Committee started talking a lot about trauma that was happening in our communities, and how the Mental Health Association could better be trauma informed and also address these issues in our education and outreach. And so we've been just talking about this as a committee for the last year or so, and one of the things that we thought would be great would be to work on our agency becoming more trauma informed. And at the same time, Sharon was working with Dr. Welzant to have him come in and do some work with the consumer quality team, and it just worked out that we were able to kind of schedule these trainings back to back to really help us address this and move our agency forward in this area. So that's it, and I'll let Sharon introduce Dr. Welzant.
And I just want to give a shout out to Kate, because it really has been Kate's leadership through CQT that she's been working very closely with the team to raise awareness about trauma and be trauma informed and really being responsive in the community, but yet taking care of ourselves as well. So kudos to you. So it's my privilege to introduce Dr. Victor Welzant. Victor is a psychologist. He's the director of trauma, the Trauma Foundation postdoctorate fellowship at Sheppard Pratt. He has been a trauma therapist for many, many years, probably 30,
25.
25 years. Plus. Yep. He is also the director of training at the International Critical Incident Stress Foundation. So he brings a lot of experience over 18 years responding in the community, helping build resiliency and recovering from traumatic issues truthfully around the world. He travels around the country speaking, hosting conferences, and he also travels around the world. I've had the privilege of working with Victor on the crisis negotiation team in Harford County. So we've been members for about 11 years as mental health professionals. So, and then lastly, and most importantly, quite frankly, is Victor is a wonderful man, very kind, and he's been a friend for a long time. So he's going to come and teach us, and so welcome.
Thank you. Good morning.
Good morning.
How's everybody? Before you answer that, I think I'm obligated to remind people we're recording. So before you, that was a joke. We are recording, but it was a joke. So you say no, whatever you say is
Recorded.
CNN picked this up. I'm amazed. So right now, you're streaming it live to all your friends. I'm totally kidding. So we're going to be talking about a couple things today related to trauma-informed care. Here's the agenda, loosely. Just a quick, and some of you, I'm assuming many of you have had some of this before, if not all of this before, in terms of trauma-informed awareness training. Some of you may do this work every day. So we're trying to just, in some ways, do a quick overview of particularly the science, what do we know about how trauma impacts people? And then how do we use that knowledge to change how we practice? Because one of the principles of trauma-informed care, although it's sort of those unwritten principles, is we're making, when I say we, I mean me in the mental health professions, have made a lot of mistakes in how we responded to people who have experienced a lot of trauma. The movement toward trauma-informed care really began in a lot of ways in the 90s with something we're going to talk about, the ACE studies. How many of you are fans of the ACE studies? And we'll get into a little bit about that, about how that really changed the way we practice, which then led to why we're here today, which is if you're going to change the way you practice, you do that at the individual level, whatever your role is, but then at the organizational level, you also change the way you think about things. You change policy, you change the way you say hello to people in the morning. I mean, it gets down to the micro all the way to the level of policy and certainly funding, which we don't spend a lot of time on. We'll mention it. We're also going to talk about the impact of doing trauma work or trauma-informed work on all of us, whatever our role is. So the idea of the potential for us being negatively impacted by our exposure to trauma. You know, we call that lots of things, but we're going to call it vicarious traumatization. Then we'll talk about the shift into how do we put this into practice? What do we do if we are making that commitment to being trauma-informed as individuals, you know, if we're going to be helping people, and as an organization, where do we go? And then ultimately, how do we, right now, what do we do like next? What are the next steps? So this will be hopefully a really good discussion, because some of this I think you are going to answer a lot better than I ever could, because, well, you work here. Come on, that was fun.
Just add one thing real quick. I just want to hit the pause button for a second and just recognize our board members. Could you please introduce yourselves, because this really, as Carrie said, this started at the board level, and your dedication and insight really to help support us as an organization. So Donna, why don't you?
Hi, I'm Donna Wells. I'm a retired mental health professional. I've worked with Victor before. I ran the Mental Health Authority in Howard County for many, many years. I'm currently on the board of the Mental Health Association now, and now on the Sheila's committee. So I'm looking forward to learning something new today.
Hi, I'm Vicki Walters. I'm a board member. I'm a licensed social worker, and I'm a treatment provider in Baltimore City Substance Use Disorder Treatment Program.
And Vicki is working with us to help expand the CQT program to our substance use providers as well. So thank you.
And I'm Sheila Cast. I'm a broadcaster and was at WNPR, and as you mentioned, I chair the Public Education Committee. And very, very grateful that you're here to talk to us.
Cool. Yeah, I'm Anita. I'm also part of the committee. I'm in the Mental Health Association of Greater Washington, a chapter from Montgomery County and Prince George County.
Just real quick, CQT, Donna was one of the founding CSAs and oversaw our grant for over a decade, I'd say, something like that.
As long as, until recently.
Right, yeah, so a lot of gratitude.
Yeah.
Yeah, thank you.
Let's jump forward. To talk about trauma-informed care, we probably have to have some mild agreement about what trauma is. That's harder than it sounds, particularly if you're a mental health professional. We like to debate and split hairs and things, but here's a really interesting, the conceptual way to think about trauma. At the heart of it, it's about how do you respond to your inner experience once it's been overwhelmed by something. And Margaret Blostein, she is one of the kind of pioneers in working with kids who have been overwhelmed. And has written about different aspects of trauma treatment. For those of you who work in this field, the Trauma Center at JRI is the home, or was the home of Bessel van der Kolk, who's also a pioneer in the field. And we've really learned a lot since 2004, but it took a long time, as we're going to talk about, for trauma to get recognized and then formally get studied, particularly childhood trauma, even though we know it's been around for a long time. We're going to get to the ACEs study, but let's start with kind of where the science landed us with the last edition of the DSM, which you all know is the manual we use to sort of parcel out how different conditions affect people. And according to the DSM, I'm going to bust some bubbles later. I hope that's okay. I'm going to bust some DSM bubbles. According to DSM, there are 7 categories of ways the trauma impacts people. Now, the good news is there are 7 categories. There didn't used to be, and now we have this whole way of thinking about trauma that the Professional American Psychiatric Association actually recognizes, that trauma can affect people in lots of different ways. It used to be that we thought mostly about post-traumatic stress disorder as the primary thing. When you thought about trauma, you thought PTSD. We know that that's really not the case, and all of you know that's not the case. There's many ways it impacts people, including something I like a lot, which is other specified and unspecified trauma disorders. I hope you don't have one of those because you don't know what that means. You know, it's, actually, it's when it doesn't, this is really, one way of saying it, this is most people who have been traumatized, right? We don't fit into neat categories typically, and our adaptations, our ways of coping with trauma don't fit into neat categories sometimes. That's okay until you go in and you know, in our current environment, if you're a mental health professional, you have to make a diagnosis for someone's insurance to pay for their treatment. So that's a challenge if the person doesn't fit into one. So now we have these categories which are really helpful. It's not just the trauma disorders. Most of the psychiatric conditions have a version of these two at the end of the list. And that's good because that's really mostly how we live. This is how people struggle. It's very personal. It's very individual, right? It's not sometimes how we thought about it. We also have the dissociative disorders, which many of them, not all, are deeply associated with trauma. And some of you are familiar with these. And luckily, we have the other and the unspecified. That's where most people I work with fit, other and unspecified. But we do know that a lot about how particularly early trauma affects people's ability to regulate their emotions and to regulate their attention and to regulate aspects of their memory. And that's what really dissociative conditions speak to, is how do we integrate those various aspects of what we take in from the world. You know, one of the key things that with dissociative disorders is forgetting. And part of the reason trauma is so hard sometimes for clinicians to wrap around is in part because it's not always remembered. It's often sort of in the background, that if someone's not actively asking you about it, you know, you may not think to mention it. And clinicians now, the good news is all the clinicians in here know that we're trained to ask them. For those of you who are clinicians, how many of you were trained at a time where it was not standard practice in your first meeting with a client to ask about trauma? We weren't taught to do that. So this is how far we've come. If you look around the room, most people have been trained, and that's really cool. But that took some work. So the DSM, when we talk about the science, the DSM is basically supposed to be created and elaborated based on the current science behind these different conditions. So every decade or so, 12 years, groups of people get together and reevaluate this based on what research has been done in that past decade or two. I think the last version was 12 years. And then they changed the categories, and they changed the way you get diagnosed with these different conditions. So that's good news and bad news. That means the science is advancing. What's the bad news in that? Well, it means we don't know everything yet. We don't know how trauma impacts people in some substantial ways. And one of the ways we don't know is the brain science. We know some things, but we don't know a ton about changes in we just a little bit about changes in anatomy and certainly changes in physiology when people have repeated exposure to trauma. And why that's so important to take into account when you're working with people who have been traumatized. Right, we'll talk about triggering. We'll talk about how reminders in the environment can bring back intense experiences of trauma. And if we don't understand that there's really a biology to that, we can respond in ways that are really harmful and actually really dismissive of people's experience, which is what we're trying very hard not to do. Somebody didn't get invited to the DSM party. It's a really important somebody, and some of you are very familiar with this concept that didn't make it into the category called complex PTSD. So this has a really long history, which we're not going to spend a ton of time on, but a couple of key things is this is the version of PTSD you get when your trauma has been repeated, when it's not a single event, and when it's in a relationship, it's in the context of a relationship that where one person has a ton of power over the other, so if you think adult-child, that's one example. This can happen in adults as well, even without childhood trauma. But you see it where people are in relationships where there's a tremendous amount of control that one person exerts over another. What are some examples of that you see in adults? Typical things that we talk about. So domestic violence relationships are like that. What else? In adults. Well, people, if you work with people who have been in captivity, so particularly people, we don't see that as much like right here in Towson, but when people come from other places where captivity is common, for political reasons, for other reasons, for social reasons, depending on their relationship with their captors, you can see this. In prolonged hostage situations, you can see this. The reason we don't is because we don't have a lot of those right here, but if we were in a place in the world where there were lots of hostage takings that went on for long periods of time, we see people with this, political torture survivors have a version of this. So we commonly think about it in terms of childhood trauma, but it's also really adult onset trauma too. And why didn't complex PTSD get invited to the party?
Because they don't know what to say about it?
Yeah, that's a really good answer. It's so complicated, not new though. They tried to propose this 20 years ago as a diagnostic category. But there's not a lot known about it because it doesn't fit a mold. And who sends out the invitations to the DSM party? A committee. A committee of people select the committee members. So all of the agreement is by committee for the different diagnostic criteria and the categories, and who gets into the meetings to do it. So you have a group of people who are focused on some areas, and then other people focused on other areas who are not a part of it. That's the only reason, I think. There were field studies of this, going back into the early 80s to show that it was a reliable concept. So that's been here.
Do you see complex PTSD in American incarceration jail system?
Absolutely.
Like that, yeah?
Absolutely. You can see it with people who did not have childhood trauma, but very often people in that setting have significant, as you know, trauma histories. So they may have it long before incarceration, and then the effects of incarceration on that, or even the people who don't have the childhood trauma beforehand, which again, you guys can tell me how many people that really involves, can develop some of these same things that we're going to look at just from the impact of incarceration itself. Absolutely. So, again, didn't make it, didn't get an invitation. It was a little sad for a while that it didn't get invited to the party. I think I've worn out that joke. Let's move on. So one way to think about the concept of complex trauma is that it's a way of sort of looking together at the ways people have coped long-term with trauma. So that's one. Some of these are coping strategies. Some of these are impacts, right? These are ways that trauma have changed certain capacities that we have, brings on certain kinds of symptom reactions, but also certain behaviors, which when we get into the ACE studies in a minute, are going to link up with things that put us at high risk for a lot of both medical and psychological pain. So let's go through just some of what this would have been if it made it in. One thing is that trauma, let me say one other thing. If we're thinking about becoming trauma-informed and we say, how do we recognize trauma? What are we looking for? This is going to be it a lot. So one thing is when you've been chronically traumatized, some people develop trouble modulating and managing their emotional life. So particularly strong, intense feelings. So what does that look like? We say affect regulation, it's a nice clinical term. What does that really mean? Well, it means you can get upset really quickly, and that stress that would typically be some people would say, yeah, that's a mild stressor, or, it's not a real bad thing. There's not a lot of discrimination between a little bit of stress and a lot of stress. People's bodies get conditioned to respond to current stress like it's past trauma. Is that, everybody cool with that idea? And think how hard that is to then regulate. So someone cuts you off in traffic, you have a massive stress response. And then how long does it take you, if you have complex trauma, if you're wired, conditioned that way, how long does it take you to come back down? Well, for some people, that's okay. You drive on and you're fine. And for other people, it can take hours to come back down. Right? That's one of the impacts. It's hard to, and when we talk about affect, think about any of the mood states. Right? So sadness, anxiety, anger, rage, any of those are possible. So these are related. Another way people over time sometimes learn to cope is by self-mutilation. And again, thinking about that as how does that help someone is a more trauma-informed perspective than thinking of it as a behavior that you have to get rid of or treat. Does that make sense? Trying to understand what's the function of it. What is the function, or one of the functions, of self-mutilation in trauma survivors?
It's a modicum of control.
It's a modicum of control, absolutely. What else?
It's a distraction from what they're thinking about.
Okay, so it absolutely can be a distraction. Some people talk about it as a way of releasing something, as a way of releasing pain. It's a way of coping with really strong emotional feelings. Some people use self-mutilation as a way to stop dissociative states. Remember the dissociation we talked about? For some people, self-mutilation helps them not be so disconnected. And people will describe it as, I feel more real after a cut, or after I hurt myself in some other way. So if you think about all those together, those are ways of coping with internal stuff, right? Internal. There's other reasons too. With complex trauma, and we're going to see this in the ACE studies too, the idea of suicide becomes a focus for some people. Now, not everybody who has complex trauma has all of this, but suicidal preoccupation. And what we're seeing is that, and all of you are seeing it too, is that that can be at younger and younger ages. And we're seeing a lot more kids, or maybe we're just recognizing it better, a lot more kids very young struggling with suicidal thinking. And this is, also what we find is as people grow up with complex trauma is the rate of suicide attempts in people with complex trauma much higher than in other kind of groups of folks. For example, people with other kinds of anxiety, or sometimes it's even higher than people who have depression without trauma. Difficulty regulating sexual behavior and excessive risk-taking go together, and we'll see this again in the ACE studies. But the theme is what? Trouble with regulating affective impulses. And it can be any impulse. These are the two that come up most often. Next thing are the dissociative symptoms. So I apologize for the clinical words, but basically trouble managing either attention or states of consciousness, so that you have memory problems, amnesia, and you have episodes of dissociation that can take many forms, but one of those is depersonalization, right? And when you hear somebody describe it, what do they say? What's depersonalization sound like?
They're outside themselves.
Yeah, a sense of being outside your body, outside of yourself, watching things from above. Trauma survivors, particularly in the ERs, sometimes people who have received CPR later will describe that experience of kind of watching it from above. If you talk to people like in the emergency room, people who have very painful injuries, car accidents or things like that, burn survivors. I worked for a year at the burn center, and a lot of burn survivors would describe this experience of watching it happen, but not really feeling it like it was happening to them. It was a disconnection. And that's depersonalization. Derealization is the same thing with the environment. What trauma does to our sense of ourselves is a major way it impacts us. It's a major way it can hurt us. And these are just some of the examples. Sense of isolation, not being understood. How many of you have heard that when you talk to people who've been through some pretty bad stuff? A sense of being permanently damaged for some people. A lot of shame. And then for some people, minimizing the impact of that on themselves. You're really minimizing the impact of trauma in their lives as a way of coping. Some people, and again, not uncommon, that we feel guilty and take responsibility for things that we had no control over, right? Things happen to us, we had no control, but yet somehow we find ways to think about that we blame ourselves. And for some people, that's a way of reestablishing control too. That's a coping mechanism. So, how do we feel about ourselves? All of those dimensions of that can be changed. Another one, and this, you see, we talked about domestic violence, Sharon mentioned a little bit. Alterations in your view of people who hurt you. Right, so our view of people who hurt us, particularly when they have that kind of long-term control over us, can change in ways that we start to take on their beliefs. Right? We start to believe and see the world kind of through their lens, through their belief system. Idealization and identification with the perpetrator, which means if somebody has so much control over you that you're dependent on them for your survival, then it's pretty easy to get into this way of looking at them and thinking about them where you idealize them. You think of them as strong, as powerful, because in your life they really are. And sometimes we have, situations where we can't stop thinking about that person, even if we've escaped. Even if we've escaped the relationship or escaped captivity, we're still afraid. It's still in our mind. We're afraid people will come back. We get preoccupied with our own vulnerability. And so people then go on to live like that. Everybody knows that trauma can impact relationships, particularly around areas of trust, and particularly for certain survivors, when you talk to them, what you hear is that they have struggles with being re-victimized. Because trauma tends not, you'll see this later, trauma tends not to happen in isolation. And so there's often many times where people are victimized. And sometimes having kind of patterns in relationships that reflect those responses to trauma. So being triggered in a relationship. And if we aren't talking about what that means, can really impact how that relationship progresses. And can impact people's ability to stay in relationships. And so when they talk in the criteria, they talk about chaotic relationship patterns. That means chaotically getting in and chaotically getting out of those relationships, as well as the time during it being chaotic. So it's getting in, getting out, and the time in between. Lots of ups and downs. Any thoughts, questions as we're going along? Just jump out, because I'll talk all day and you don't want that, trust me. Another area where trauma really impacts is physical. Particularly physical symptoms, but just in terms of the stress response in general. If you've been traumatized a lot, we all have stress responses every day, right? Something stressful happens. Our body responds a certain way. If we went around the room and I asked you all, how does your body respond when you encounter something stressful? Let's say the saber-toothed tiger, remember the saber-toothed tiger? Mm-hmm. Walked into the room right now, we all would have a stress response. If we went around the room, wouldn't they all be maybe a little bit different, what we would notice first, and second, and third? Most of us would have our own little version of it. But that little version of it can be remarkably consistent. So whether it's a saber-toothed tiger, or someone cuts me off in traffic, or I'm in a line and it's too long and I'm annoyed, the physiology can be the same. The intensity might not be, or it might. But if you tend to respond with muscle tension to one stressor, then chances are another one you would too. Does that make sense? We're all kind of have our habits, our patterns. And sometimes those patterns get activated in situations that are not traumatic. right? So the annoyances can trigger that kind of reactivity. What does that reactivity do over time? Well, it can, one of the best definitions of stress, a guy named Selye, remember him from Psychology 101? He said stress is the sum total of wear and tear on the body. So that activation of that stress response is the mechanism of that wear and tear. And so if that's going off a lot, if we're highly sensitized, triggered a lot, we can do things about that. The good news is it's something we can do a lot about. But if it goes unchecked, what you have is different symptoms of different expressions of that stress response that keep going. So stomach problems. Anybody know people who have stomach problems under stress? Yeah. Anybody? Chronic pain can be contributed to by this. It's not causal, but it's a contributor. So people with, when you look at the rates of chronic pain conditions, and people who've had a lot of trauma, it's much higher. We don't have immune stuff up here. We're going to see that later in these studies, but immune conditions. How about cardiac issues, cardiac symptoms? What are some of the cardiac symptoms that you see in people who struggle with?
Blood pressure.
Yeah, hypertension, right? Chronic stress contributes to hypertension. It's not the only way we get there, but what else?
Heart palpitations.
That's a good one. So some, I'm having those right now. Heart palpitations, right? And the way you can do a little self-pulse check here and say, okay, think back to the last time I was really stressed. What happened in my body? What was my pattern, right? And see, was it a stomach thing? Did something start hurting? Was there trouble breathing or something in your chest, thumping in your chest? Or did you feel flushed? And usually that means whatever it means to you, but your blood pressure might be going up. Then there's a range of symptoms called conversion, which simply means there's a problem and they can't figure out kind of a medical explanation from it, but they know it's kind of correlated with stress or conflict. So what are some examples of conversion?
Would insomnia be one?
Insomnia would be definitely one of the symbolization things. Yeah. With conversion, it's we don't see these a lot, but have you ever heard of somebody who had something, we used to call it hysterical, so hysterical blindness or hysterical deafness, where you can't, it's either a sensory thing or a motor thing. So sometimes people lose the ability, they'll describe it as, my arm's paralyzed. And then they take them in, and they run them through an MRI and a CAT scan, and they do all the neurological testing, and everything's working okay. Doesn't matter, the person still can't move their arm. That's conversion if there's no medical explanation. And that can be treated with psychological help. Psychotherapy can help that. So it can be sensory, it can be any sense, but it's typically vision and hearing. And it can be motor, which is typically loss of motor function.
So is that kind of what happens when you're in that, when you're sleeping and you're like completely out, you're in that REM sleep, but yet you can't physically move or react and you're just like, ah.
It feels very, people describe it as very similar to that.
Yeah.
The way that happens, I'm not sure it's the same mechanism, because with that, if you wake up, then that goes away. With this, you can be completely awake and still have it. So it's probably not quite the same thing, but it feels exactly the same. Yeah. It's like you're awake, you know you should be able to move, you can't, and it's like...
Yeah, and you're trying to get out of it,
Yeah.
and you're just like, what is happening?
Absolutely, absolutely. Lots of reasons that happens. Has everybody had that experience? Where you wake up and you can't quite move yet? Us? Yeah. It's pretty common. There's certain sleep disorders where that happens a lot, where people have that a lot. Those can be treated too. That's really cool. Not cool if you have it, it's cool if you can treat it. And then sexual symptoms, sexual symptoms are also one of those categories where people can have, and it's typically sexual symptoms that when you go into a physician, they don't necessarily have an easily identifiable cause. And pain is probably the most common, it's not unrelated to this. It's some kind of pain associated with sexual activity. So lots of physical things. And then how we think about life, how we think about our future, how we think about the big picture, how we make sense of things, what we turn to find meaning in life, all can be impacted by our early experience, particularly if that's, negative or positive. But the extremes tend to impact us. And so things like despair and hopelessness. And that can be, the reason it's up here separately is it actually can be separate from depression. Right? People can be despairing and hopeless when they're depressed, but you can be despairing and hopeless without being depressed also. And it's important to understand that because how do you work with this? It's really different. And then for some people, it's something they used to believe in, now they can't. And it's whatever they used to believe in. But for many people, it's faith. Sometimes their faith is impacted by some bad experiences. Right? And again, that can be people recover from that too. So that's what it would have looked like if it was invited. It wasn't, but that's what it looks like. If you're saying, what do trauma survivors struggle with, particularly long-term trauma survivors, probably some combination of these would be out of the range of what you would expect. Because these are ways people adapt in ways, and that's why they call them adaptations. They don't focus on them as symptoms. A trauma-informed model focuses on these things as the ways you have adapted. So chronic pain is maybe a body's way of adapting to certain kinds of muscle tension, certain kinds of neurological changes that are a result of a lot of activation. So comments, questions, thoughts?
It's mind, body, and spirit. It's mind, body, and spirit.
Mind, body, and spirit, Cheryl, absolutely, absolutely. Now, are these things, all of these adaptations, ones that can change and get better over time, with work, with therapy?
Yes.
Yes. Right. So that's why we spend so much time thinking about being trauma-informed, And there are all kinds of metaphors for this, but there are lots of things that can happen to our bodies and our minds that once they happen, we're trying to cope with it, but it doesn't necessarily change. Certain kinds of head injuries, right? Certain kinds of brain injuries. You have them, okay, then you work with them. These are things that can change. You have to work with them too, but these are things that get better. And part of the reason we get so focused on trauma-informed care is because for a long time, people who had trauma responses like this, they weren't recognized as trauma responses. They were diagnosed as other things. So then you get into kind of a treatment model that may help some, but isn't really designed to deal with what you're dealing with. As opposed to, hey, if we're trauma-informed and we recognize this, we can get people into trauma-informed care and puts the odds in their favor, right, of getting the right kind of treatment. And that's why we're so passionate and committed to helping people learn about this and talk about organizations, how to get the word out to the community too as a part of some organizations' missions, to educate other people, providers, and peer supporters, and everybody in how to do this, how to recognize and get people into good care. So, one other way to look at the impact, and then we'll move away from the science. Some of you were thinking, wait a minute, I thought we were going to do that 20 minutes ago. Science is great. Check time, okay. The ACE studies were for trauma-informed care, the game changer. And this was one of the most profound contributions to the study of trauma and to the development of trauma-informed care that exists. And when you see the scope of it, you'll see why. We'll walk through the study, but what they were attempting to do, this was Kaiser Permanente, actually California, and the CDC collaborated on this. And they interviewed people in the Kaiser system about some traumatic experiences, which we'll get to. And what they tried to do was identify what were the long-term correlated issues. And they looked at psychological issues and medical issues together. And they tried to develop a model that explained how we got from these really awful things happening in childhood all the way up to these risks that led to the diseases we're going to look at, and up to and including early death if left unchecked. And the reason it's early death is because of some of the health risk behaviors, which we'll get into. And they're trying to create a model that explains it from the level of how do these kinds of experiences activate our genetic, our predetermined genetic potential for certain diseases. Right, so it's one level of the study is looking at the gene-environment interaction and how stress can trigger the expression of certain genetic traits that we might be walking around with. Right, we all have certain vulnerabilities, so it might be to heart disease, or it might be to endocrine problems, or it might be to red hair, runs in families, whatever it is. But lots of things don't get expressed until something in the environment activates it. That's what the epigenetic studies are about, is looking at that link. And they wanted to do that for trauma. They wanted to look at how does the trauma at an early age lead to some of the health things that they studied. Why, in part, it was a game changer was that number right there. How many of you have ever been a part of research projects, like for school or anything? Anybody? Yeah. How many people do we usually have in our research? 30, 25, 30, Graduate students, that were lucky if we had 50. If we could get 50 people to volunteer, we were doing backflips, right? That's a lot of people. What that means is the conclusions have a lot of power to explain things, much more so than 30 people would. They looked at, initially, a smaller group. They've expanded this since, of what they considered adverse childhood experiences. So looking at, in the house you grew up in, was there substance abuse, separation or divorce, did one of your parents have struggled with a mental illness? Was there violence? Did you witness a lot of violence? Did you witness a lot of criminal behavior? Then they looked at specific forms of abuse, psychological, physical, and sexual. And one of the brilliant, literally brilliant things they did was they also separated out neglect from abuse. And we almost take it for granted now how important neglect is of the adverse development. But there was a time where we really focused much more on abuse and didn't pay much attention to neglect in terms of the long-term outcome. So what they found in that 17,400 plus people was percentages of people who said yes to these different experiences. So would you consider that a low or a high set of numbers? Yeah, you could say that. That's a lot of people who have been hurt. That's a lot of people who have been hurt. So now they looked at it in a little more detail, and we talked about this earlier, that lots of times these things, we break them out for research purposes. People don't live that way, they live them together. So there's multiple adverse experiences that you go through simultaneously. And what they tried to do was see, of that list we just looked at, what percentage of that 14,000 had none? Only a third. Only a third said, no, I haven't had any of that stuff. Right? So 2/3 said, yeah, I've got some of that stuff. 26%, yeah, had one of those, check yes to one. 16, 2, 3, 10%, and 4 or more, 16%. That's huge. That's a lot of people. If that number holds true to our country as a whole, which, again, 15,000 people, you could argue maybe it would, that's a lot of people who've been hurt. And then they wanted to know, so what was the outcome? So they followed people over as long as they were enrolled in the Kaiser HMO system and were willing to participate. So let's look at some mental health outcomes first. Attempted suicides. 0 ACEs, 1, 2, 3, 4 or more. What do you see? For those of you who love statistics in the room, that's an insane trend line. That it doesn't get really much cleaner than that, which is not a good thing for this particular thing that they're looking at. But 4 or more, 20% of the sample had attempted suicide. Lifetime history of depression. They also broke things down by identified gender, men and women. So 0, 1, 2, 3, 4 or more. Again, not good news, right? Both men and women. The more ACEs, the more likelihood, the more correlation you have. Being a victim of domestic violence. Now, this did break down differently from women and men, which, again, most of us wouldn't be surprised about, but what do you see?
Higher ACEs, higher prevalence.
Same, absolutely, same trend. More ACEs, higher risk. Here's one that I don't think anybody was or is that surprised by. I think this is one that just intuitively we get, that drug problem, drug addiction, and intravenous drug use. Particularly now, this is actually a little different. When you hit 5, it doesn't follow the trend line. It skyrockets. It's a very different pattern than what we saw before. So what percentage of people, drug problem in that sample, 12, IV drug use, 4%. Again, higher than people who didn't have that kind of trauma. They also looked at medical outcomes. So they looked at HIV risk. And they looked at dimensions. Remember we talked about sexual behavior under complex trauma. They looked at just different dimensions of combinations of drug use and sexual behavior, or sexual outcomes. So injected drugs, again, 4 or more, same trend line. At 50 or more sexual partners, not quite as clear of a trend line, but ACEs, still higher than if you have 0. And STDs, again, same trend line, steeper. So you see a pattern starting to develop, right? Bad things happen to you, risk for some bad mental health outcomes. And now we're looking more at physical outcomes and what they call, a term they use, health risk behavior, right? So sexual behavior is one example of that, smoking another. What do you see? We could just keep going, right? It's like the same pattern. Current smoking, 4 or more ACEs, really much higher risk. This is 0. This is the comparison line, right? This is, as you increase the number of ACEs, you increase basically risk. COPD, so if you think current smoking, starting smoking early, or long-term outcome, COPD is 1, right? It's not the only one, right? Obstructive pulmonary disease, higher with more ACEs. Heart disease, ischemic heart disease. What's it tell you? Less of a clear trend here, right? 4 or more, what do you see? Clogs us up. That's a bummer. You don't want to be clogged up, right? Is there a mechanism that could explain that in terms of stress? Physiological mechanism that could explain increased?
Cortisol?
Cortisol.
Yeah, absolutely. Absolutely, cortisol. When epinephrine, which is one of the primary stress hormones, cranks through your system, particularly repeatedly, it scars the inner lining of your blood vessels. Those scars are where plaques connect to. That's where it starts. Does that make sense? You have scarred vessels. Those plaques attach there and build and build. So that's a possible mechanism. We don't know that is why everybody gets that. But there's a physiology to almost every one of these things we're looking at, which is good to know. So to try to summarize, what the ACE studies did was focus attention on childhood trauma, but from the public health point of view, which is a completely different thing than focusing on it from a psychological or psychiatric point of view. It brought the attention of a whole set of resources in the public health world to this problem, which is why it was a game changer, which is awesome.
In the slide on depression, there was a real disparity between the men and women. Is that because more women seek treatment, or how would you explain that? Because that was really noticeable.
I think it's probably a combination of more people seek treatment, but also in studies not looking at childhood adversity, looking at rates of depression, you see the same thing, the same trend, not focused on childhood trauma, where more women are either have depression or are diagnosed, get into treatment. But even in studies that are not treatment studies, the rate of depression in women is higher. So there could be multiple other reasons, including
These are people who
endocrine.
have the same number of traumas. I mean,
Right.
that's what caught my eye, is it seems like there's a disparity.
Absolutely, absolutely. I think there's multiple reasons, and one of them, I think you're right, it is diagnosed more. The thing about the ACE studies was they weren't people necessarily in psychological treatment, and you had to still say yes,
Yeah,
right?
yeah.
And if you're a man and you're looking at that,
Yeah.
you don't,
Okay.
you're not comfortable
That
saying
explains
yes.
it.
Yeah. So what did they conclude, again, in summary? Number one, these are really common. When you look at the numbers, these are common outcomes. They are highly interrelated. So you don't just have one of those risks, right? You have as many as you have, but they're interlinked, right? So if you think about something like drug use, you can have multiple bad outcomes because of that then lead back to the childhood trauma. Cumulative stressor effect, and they have biologically plausible mechanisms of action for each of the ones that we've talked about so far. And one of the things they've done subsequent to the initial studies is add more variables to the list. So now they're going back to the same database, as well as collecting new data, and studying newer, or not newer, but different outcomes. So they're looking at things like risk of revictimization, stability of relationships, homelessness, workplace performance. I mean, they're just looking to see what are the long-term impacts. And there'll be impacts that they study where there might not be, such a severe impact, and there'll be others where it will be severe. Reproductive health. The initial sample was with adults. They're also replicating and have been publishing data on adolescent health too. So looking at just different age groups. Where's it going to go from here, do you think? Kids, right? So they'll start looking at that too. When I say start, I mean they'll start publishing it. They are looking at it. And again, just in terms of many of these are leading causes of death. We didn't talk about liver disease, but what's the potential mechanism, one potential mechanism between ACEs and liver disease?
Alcohol.
Right, absolutely. So, I mean, you see the connection, this is, right? Everybody, questions about the specifics? Okay. So, strong predictor of health risks, strong predictor of disease across the lifespan. And depending on who you believe, actually some of these slides were from a briefing that was done by one of the developers of the study that he did to Congress after the initial set of publications came out back in the 90s about this to try to secure funding for more research. And what they concluded was it's one of the leading adverse childhood experiences, one of the leading determinants of health and social well-being of our nation. Right? And when you look at what can account for some of these negative outcomes, and you see the numbers, that accounts for a lot of the variability, a lot of the variance in those different outcomes, more so than other single causes. So, thoughts, questions?
Well, you've got to wonder if those numbers are low, if the sample of 17,000 people were people, all of whom had access to health care through Kaiser.
Absolutely
Well,
right.
that's very true.
Absolutely. If we did this somewhere else, let's say we did this with the Maryland MA population, we get different results. Absolutely, and we should be. Right, I wish we could do that.
Victor,
Yes.
could you say a word or suggest a reference on what you feel is like the cutting edge in terms of treatment for this, like PTSD or anything?
Sure, and a bunch, I can actually give you a couple. one of the things, we're gonna take a break in a second, one of the things, that's not up here in words, but is a really important concept, is that how do we, if we see this trend and we want to impact it, treatment is one way we impact it. What's the broader way we impact it? Think public health, how do they solve problems? What do we need to do to impact all these negative outcomes?
Education and policy change.
Right? Education and policy change. And the initial focus from a public health point of view, just this is common sense, but sometimes we don't think this way because we think treatment, prevention of the ACEs to begin with.
Yeah.
And that's education and policy change to teach people, no, this hurts kids. Don't do this to your kids if it's at that level or at the organizational level. How do we fund resources that help parents manage their own stress better so that this doesn't keep reoccurring? Prevention is what public health is all about. And what they have concluded is that the ACEs are one of the more preventable risk factors for long-term bad outcome in health. Preventable. With exactly what you're talking about. Policy change, funding that helps teach and educate parents or people who are at risk for this. Who have we educated so far?
Professionals.
Yeah, lots of healthcare professionals, mental health care, physical health care, social services organizations, foster parents. There's entire organizations teaching the ACE study material to foster parents. It's great stuff that's getting out there. But it's like anything else, you gotta have money to do it, right? You gotta have people who know about it to do it. So, there are organizations that will come to your organization or other organizations for free and do little presentations on the ACE studies. But anybody can do this. Anybody can take this information and make it appropriate for the group you're teaching it to and go from there. But prevention, that's kind of the note I'm enjoying. We're going to I'll talk about treatment right after the break and just give you some references. Why don't we take 5?
Oh, you didn't eat it?
Are we done?
If it wasn't, if it hadn't been so quiet, I might have eaten it, but everyone would have heard me like,
and taking care of the impact of doing trauma work, if that's what the organization does. One of the people who are doing the work, because a trauma-informed organization thinks about it broadly. It thinks about not just the people we serve, but the impact on all of us as well. And we know there's this idea of vicarious trauma, and to keep it really simple, because we try to relate to people empathically, we often absorb some degree of the pain that we are hearing about. We're not robots, we're not mechanical, we feel. And sometimes that can lead to us having some similar stress reactions to people that we are helping who have been traumatized. And there are things we can do to protect ourselves from that. And, I know we've talked about this before. There are lots of reasons this can happen. And one is because our own trauma experiences can sometimes be activated by what we're hearing. So that's one way we get to that place of vicarious trauma. Feeling super responsible to help people can, in some ways set us up for unrealistic expectations sometimes. So that's another mechanism. So we get too hard on ourselves in terms of what we can expect to be able to do. When the trauma involves kids, for some of us, that's just its own vulnerability. Hearing kids' trauma may be different for some people than hearing adults' trauma. They're both horrible. They're both awful. But for some people, kids. Who is it that's more vulnerable to kids? We don't know, but one thing you hear a lot is people who have kids the same age, sometimes it really stirs stuff up. And that makes sense, but there's lots of reasons. And then immersion. And what we, one way we think about that is just how much of that kind of work do you do? If you spend 6, 7 hours a day, talking to people, doing groups, whatever it is, where, that's a huge amount of working with trauma. One of the strategies for therapists that they suggest to avoid this is to pay attention to the number of hours you spend listening to trauma, doing trauma work as a therapist. You really pay attention to how much of your day is devoted to that. And that's why you'll see therapists sometimes doing multiple different things, different jobs, and they'll teach or they'll do research as well as therapy to try to have more of a balance in what they do. And balance is an important part of dealing with this. So I'm not going to spend a ton of time talking about the details of this, because I think everybody knows what it looks like, and if you've ever been in that place, you know what it feels like. How does it impact our work is an important question. And there's lots of ways that it can impact our work, including us having to put up our own barriers and defenses, which can make us a little bit less effective or a little less empathic. And then it also could show up in our life outside of work, a range of things, all the way from just being too drained at the end of the day to be able to go out and do things that are balancing, all the way to changing our perception of the world itself, of people in the world. And the classic thing is the trauma therapist who, after a couple of years of doing it, realizes they start looking around, like in the grocery store, and wondering about these people and how they're behaving, with their kids, and but it happens. We change, and it can happen not just in that way, but there's lots of ways our perception of the world, particularly around safety and around people's intentions, can get over time eroded by doing that work if we're not paying attention. So the awareness is the key thing. The awareness, talking to people, having colleagues who you can talk to when you're just completely done, right, Sharon? Sharon gets a phone call and I'm completely fried. And it can obviously shows up in her work, but outside of work. Are there ways to minimize the risk? Absolutely. Anybody have ideas what you do?
I think good supervision is critical.
Supervision.
Of the therapy.
Absolutely. What else helps?
Well, in line with supervision, peer support. I've always found peer support in clinical settings is really helpful.
Absolutely. Who do we turn to, right? People next to us, people who are going through it who know what we're talking about? Absolutely, peer support. Lots of things help. The take-home message, sorry about the, I dropped my E and my S. I've done that a few times. That was a quiz just to see if you were noticing. The thing is, you have to find some individual things that work for you because we're all different, but what are things that help restore balance, restore positive energy into your life? Those are the things we have to think about. All kinds of things that we can do just on a daily basis, things like exercise and paying attention to self-care and diet, nutrition. Are we expressing our feelings in whatever way works for us? Writing, art, talking to people. Are we doing things that are outside of work, doing things we enjoy? And are we doing things that recharge our batteries, but also in that deeper way? Things that help us reconnect with what's deeply positive in our lives or in the world, that help balance out our awareness of what people go through and what people have done to each other. The other thing is we once in a while have to remind ourselves of how much the work you're doing is actually making a difference in helping people, because in the day-to-day sometimes it's really easy not to think about that. You just go from thing to thing to thing, and every once in a while stepping back and saying, wow, okay, here's what we've done this week or this month. There's some things you can do while you're listening to people who are suffering from trauma, but I'm not going to spend a ton of time in the moment. Do things like taking breaks, paying attention to how judgmental you're being with yourself. And we were talking with the team, the quality control team here. Doing this as partners is really an effective way, not being the sole person in the room. It's a very different experience. It can be really helpful. You know, and being a team, and I think we talked about peer support. You know, we're doing this as an organization, we're doing this as a team, using the resources of that team, reaching out, you know, not just when we're upset, but reaching out, checking in with each other. How are you doing? I heard you had a really difficult situation yesterday. How are you doing with it? Really that kind of caring for each other, I think can make a really big difference. So what else about vicarious trauma? What are some things you've observed or you found helpful?
I think trying to watch my mind as, because like, you know, when we go on our interview, on our visits, you never know what people are gonna decide to share with us, and it's, you know, I'm still learning about what triggers me, like what I'm, you know, I don't know what I'm gonna hear or how I hear it might affect me in some way, in the moment or later on, but I think it's important to watch my thoughts and feelings as they arise.
Knowing that kind of awareness and knowing to do that and knowing yourself and what your triggers are is really an amazing part of kind of keeping this in check. And I think, I mean, how many of you who've been doing this for a while, every once in a while still hear something that just sort of knocks you off your feet and you weren't expecting it?
Yeah.
I mean, I think people have been doing it for a long time, even when you know your triggers. Once in a while you run into something. So that kind of awareness of how am I doing right now is really important. That kind of mindful awareness is awesome.
I think it's really important to have coping skills built into the office and into the workplace. Like growing up and even in my early professional life, if you needed to take time, you went home, right? And it was something that I had to learn to integrate. It was like, well, I'm going to keep a coloring book in my desk, or I'm going to start integrating these little things in order to keep myself working. Otherwise, I'm just going to, I'm done.
Right.
You know?
So, you know, what we talked about the last time we talked about vicarious trauma was just thinking about what works for you, and then just checking in with yourselves and with each other, making sure that that's become integrated into your practice, into your day, into your work, into your life.
So maybe it's too early to ask you, but we're right here. In those moments where we hear some very deep stuff, and do you have any suggestions on how we can protect or set boundaries in the moment so we don't have to relive that moment with them in a professional manner, and it not being so like, you know, just kind of eliminating yourself from it?
Absolutely. So one thing is that ability to get into and be close and empathic with somebody, and then be able to psychologically, not physically, step back. And we can practice that in just everyday conversations, the going in and being close, and then stepping back and being more reflective of what we've heard. So that's a skill. But when you're hearing really awful stuff, sometimes it's just not, you're just in it. So one thing is, if you tend to be a visual person, like if you hear something and you tend to create an image of it, try to focus more on the words rather than creating a visual image. The visual image, because then we'll play that over, it can be really traumatizing. If some of us are much more visual, some of us are much more auditory, try not to create that visual image, but just repeat in your mind, what did the person just say? I'm gonna be there, but I wanna reflect what they said without trying to create that image. That's helpful. I think taking breaks can be helpful. I think doing things that are grounding in the moment, so that if you're really in there, what can I do to draw back? Okay, well, one thing is I can move my body, I can pay attention to the room. What do I see? What do I hear? What do I feel? Feel my feet on the floor, just to get a little bit of distance from it. I think sometimes that once we're in it, and what we have to do is afterward, do a lot of self-care things. And one is, how do we talk to ourselves both during and, the self-talk, during and after. One is the boundary that you were talking about, saying, this is this person's story, it's not mine, I'm here to help them. Now, when you're overwhelmed or triggered, most of us can't pull that off, but maybe going into it, we can, like preparing for that conversation, if we know. I can be present and I will take care of myself afterward. And that's where, right away, I would try to use my partner to say, hey, how are you doing? Are you okay? Can I talk to you about this? Because I was really affected. Or call somebody, if your partner, maybe it's the kind of incident where your partner's going through, call somebody you trust and say, hey, can I talk to you for a few minutes? And try to start that process of processing it as soon as you can. But I think it's really trying to have that boundary. And some people even do visualization to put up a boundary, so that's another option. I haven't done that, but that's one that people talk about, can be helpful. It was like visualizing a shield where you're able to be empathic, but the other stuff's not able to get in. If that makes sense. And that's just a little strategy. Other thoughts? Because I'm not the only one who probably had to struggle with. With hearing stuff that's just so compelling, you're so into it, and it's like, whoa. Anybody find other things helpful?
So we're taught to redirect people out of their trauma history stories and try to ground them into the present. But time, can be very difficult to nail down when someone's in a traumatic memory. And then the experience that James and Amy had, a woman was triggered because it was the 20th anniversary of being liberated from a horrific experience. And so she went into this, and there was no stopping her, right?
Yeah.
And so it's that, how do you mindfully try to stop someone from flooding? I like the visualizing the boundary thing. I think that's potentially helpful for us. I know Arlen and Kevin were just at a hospital, and they had a similar experience where someone came in with lots of papers, and they had their story, and they were going. And as Arlen and Kevin were trying to navigate around that and ask if they were being served in the hospital to help with this trauma, this person was not allowing them to interject or ask questions. They had their story and they had to tell it. And it's just this feeling of, it's an immense feeling of distress navigating that. So I don't know if any of you four want to talk about that anymore, or...
So the experience that I personally felt, I'm new to the CQ team, was she started to, we were kind of mesmerized at how quickly she went to that, because we weren't going there. It was a simple question, how's the program treating you? And then it was like, boom. And just straight reliving that. And she shared what she shared, and it was intense, and it was extremely uncomfortable, to the point where I was taking notes, and I put my pen down, and it was just like, done. I'm like, I gotta document, take notes on this. Yeah. So it was quite intense, and I know for me afterwards, even we continued to interview other consumers after the fact, was able to kind of pick back up, but I'm still processing what I heard, almost 2 or 3 weeks later.
Yeah, we had a similar situation, Arlen and I. As Kate mentioned, a woman came in prepared, was expecting CQT. and came in with a notebook, which she keeps religiously. She journals all the time. But her notebook was full of lots of information regarding a long personal history of feeling as though she had been abused, neglected, persecuted. People have stolen from her, people have beaten her, people have hurt her physically. And so we tried to redirect the interview to provide empathy and then simply ask her, well, since you've joined the program, is there anything about the program that has been helpful to you? And repeatedly, her response was, wait, you need to know what I've been through. You need to hear this story. And so there was no stopping it. Ultimately, she decided that we were part of the scam being perpetrated upon her by everybody in her past, everybody at the hospital, and we were just part of that continuum. And she stopped. But it was, is that about it, Arlen?
Yeah, I mean, she stormed out. I mean, it was very difficult. I mean, I think personally for me, I didn't realize it triggered me more than, I was not prepared for that at all. And I think for me personally, I felt that I kind of even did a disservice to Kevin because I kind of just froze and I wasn't able to bring her back while he was taking notes. But yeah, it just hit a spot of just a personal thing that I'm going through, and yeah, it was hard to, you know, shake it off, and, you know, like James said, you know, you still think about it, even though it's now been like about a week, or you still go back to that place, like, what did I do wrong, you know, how could I have made this better?
Yeah, I think we handled it well as a team. I mean, we try to come up with ways to, at a certain point, if they're beginning to flood, and it's apparent that the more they get into their personal stories, that they're self-triggering, that as they relive their difficult personal histories, they're getting more agitated, so we're not doing them any favors, you know. So it's hard to think of a graceful way out where you're sort of maintaining an empathic connection, where you're maintaining empathy, but you're also trying to find a way to extricate yourself, not only for your sake, but for theirs. And the only thing that we could think to do at the time was, well, let me make sure that we've written down, you know, some of the harsher things that she told us about. Let me report this right away. Let me, you know, we've got it, we've written it down. Let me report this to some people here so that they know what's going on. But, you know, that in itself was a betrayal in her mind because we weren't letting her finish her story, although it was serving neither her nor, although it wasn't serving her. So I don't know if there's a tried and true way to extricate yourself from a situation like that. And that's the second time that's happened to me in the last month and a half, you know. So.
You know, I think it's an incredibly painful spot to be in. And it does sound like you tried things that are very reasonable and good to try. And sometimes, and this is I think this can be a hard thing for all of us. Sometimes there's not anything in the moment that will redirect it. But you keep trying. And you can also, you know, just ask, yeah, if somebody's gonna not let you interrupt, they're not gonna, you know, there's not much you can do. But I think one thing you can say to someone, if they let you, you know, is, this looks really upsetting, and I really care about what you're saying. I just want to check in and make sure this isn't causing more pain than it's helping. But somebody has to let you do that. And if somebody is flooded and they're not letting you do that, it won't work. And sometimes that's just the nature of them being triggered, that it will end on its own terms.
She just wanted to receive her, you know?
Yeah, absolutely.
And that's how, like, Amy, I don't remember exactly how you were able to kind of navigate away from that, but I remember she followed up with, so, you know, basically the program is Pathways, are they providing the support that you need? And even though we heard what we heard and had to kind of relive that with her, by the end of the interview, it actually was a very positive experience. So, as a note taker though, I was kind of like on this thin line because I needed to make sure that I had captured everything she said, but I also didn't want to have to revisit that with her again to make sure everything that I had written down was exactly what she said, because I was like, so it was like it was definitely a learning experience for me. It opened my eyes. So
Initially, I was kind of getting lost in the image I was creating from the description she was sharing. But then I kind of focused on this person right in front of me who was speaking quite well and was even making jokes with us. So that got me to be present. And she said she was doing well. So walking away after that, I tried not to be hyper-focused on kind of the horrific details, but how she was doing present. And then mentally, I also got into action mode, so when she was sharing A, B, and C, then mentally I was saying, okay, then I want to ask A, B, and C to assess the current situation.
I'm distressed hearing that CQT is going through this. I had no idea that these are the kind of things. I guess my thinking is, as a clinician, is this is the way this woman identifies herself, by the trauma. That she doesn't identify herself any other way, which is why she's got to tell you. And that's very sad. That's her, the way she's self-identifying. It's very troubling to me that seems to be the case with some of the folks that you're dealing with.
Well, yeah, but then you do, and then at the end of the visit, you're reporting out to the leadership there. And you're hearing from leadership, well, this is a daily occurrence.
Right.
This is just
I'm not
something.
surprised.
This is something she does. But then, you know, you want to report it out because perhaps the treatment team is making progress, perhaps they're not. I don't know.
Sounds like
You
she's
know,
not getting trauma-informed
you
treatment.
know, I don't. So all we can do is like underscore, yeah, well, but you know, sometimes the reaction is, yeah, we know. That's every day. You know, why is that a safety concern? Well,
Just a question,
yeah.
could there be a sense of manipulation here? You know, that could she be manipulating really?
Yeah, we don't, so with CQT, we don't engage in any sort of diagnostic, you know, we don't know people's medical records, their history, unless, we meet people where they are. So whatever they're telling us, we just see it as a neutral party.
It's never about judgment or questioning the narrator. It's never about that. Ever.
I understand the question.
You know, I
Yeah.
mean, you know, the client,
Right.
him or herself, you know, manipulating, you know.
Well, I think probably when the manipulation is more attention-seeking, where,
Okay.
you know, she has your attention and she's telling her story. But the sad thing is that's the only story she has to tell.
Okay.
That's the sad thing to me. She doesn't have another story to tell.
I was just gonna ask, I mean, like, in that situation, I mean, you know, you do get into a situation where sometimes people just, they need to kind of word vomit on you and get that story out.
Absolutely.
As a way of putting a barrier in, can you say to a person potentially, you know, it's clear that this story is really important to you and you want to be able to share that with me. Let's take the next 5 minutes for you to share as much as possible about this story that you think that I need to know. And then there's like a time cutoff almost where you can say, okay, you know, we've talked about this. You've given us, you know, we've given this person the opportunity to give us whatever they need to give us in that moment. but then being able to say, okay, now, you know, we've gone through our 5 minutes, let's look at a different question, and, you know, maybe you need to come back later, but to kind of give you guys an opportunity to sort of step out from that for a minute too. Is it ever appropriate to kind of give someone a time limit to tell that story in the moment?
Perhaps, but they may not register time with you either.
Right.
So that just happened, was it, I guess David and I were together, and somebody came in and she was very anxious to talk to us, and she said, how long can I talk? And I said, well, you know, interviews, you know, she said, I have a lot to say, and I said, well, you know, usually, you know, not that long, whatever. She said, was 10 minutes good? I said, well, that sounds really good. And as I said, but 35 minutes later. But sometimes I have had a chance to say, and Kate knows this, to say, like, I'm really, you know, I understand about your story, but unfortunately, there's really nothing that we can do to help with that story that happened, because we're really here to focus on what's going on here now in this program. Sometimes that has worked, doesn't always work. But I mean, you know, we're writing it down and we're gonna tell somebody they're still thinking about this thing that happened, not ignoring it, but sometimes it, you know, it just, it feels bad, because I think from what I feel like in that situation, but I can't help them with that story. There's
Right,
nothing that I
exactly.
can do, and I feel like it's sort of a disservice to sit there and listen for 45 minutes and then just like they basically say, well, no, too bad. I mean, you know, because they're hoping so much for help,
Right.
and we can't give them that help. So that's a big problem for us.
Yeah,
Don't you
I agree, yes,
Yeah.
yeah. And we're not, you know, we're not trained as clinicians, so I just worry about everyone navigating that, and where we really are to see, is the program providing the services that you need? And that's our role, like Susan said, you know, we cannot help them process this story, we just simply can't.
But sometimes their problem is that they don't feel listened to by staff.
Right.
But
Then
you
the
say-
service,
then you
then the
say,
service
Kevin,
we're providing is,
If you're listening.
But then you say,
the
I'm
listening
gonna
that
tell-
that needs to be cut off.
Right.
Then you say, I'm going to tell staff that you're still worried about this, and I'm gonna have somebody talk to you, or try to get somebody to talk to you about this. I mean, assure them of that, you know, then hopefully they'll feel reassured. But probably all the staff has heard this 35 times.
I'm wondering if there's any science behind tapping as a self-care strategy.
Yeah, I know there is, but I don't know it, because it's not something I've used or had any training in, but I do know there is a science that comes with it. I just don't know anything about the, you know, the quality of it. But I haven't had any training in it. I know people who find it incredibly helpful. I know people who teach it and find it incredibly helpful. So,
Do you?
let's, if we could, let's,
Teach us?
a few more, because I know we're.
We have 20 minutes.
Talk a little bit about that shift now from looking at the science, looking at the impact on us, to thinking about what does this really mean? And some of this we've touched on. What does it mean to be trauma informed? One thing is just to have a basic awareness of, when we say trauma, what does that mean? What are the different ways we experience trauma? So single events, you know, which again can be anything, can be adulthood or childhood. Chronic trauma, which is where a lot of the folks who have had those ACEs, that's what we hear about, where it's just multiple traumatic events over a longer period of time. Complex trauma, I think we spent a lot of time talking about that. What we haven't touched on is the trauma, and I think you talked about incarceration earlier, asked about that. I think system-induced trauma can happen in a lot of the treatment settings and a lot of the correctional settings that we work with. And part of trauma informed is also trying to educate people in those settings about that impact. And some of that work does get done, but I think we'd have to look locally first and say, okay, well, where is that being done? How is that being received? That can be, you know, through even processes that are designed to protect people and take care of them can be inadvertently traumatizing, and some settings are just overtly traumatizing. And I don't know how many stories you've heard about that when you go out, interview people. But we want to keep in mind that what we're doing to help sometimes can inadvertently reenact or re-trigger people in a way that their post-traumatic reactions are going to flare. And that's inadvertent, but then there's also aspects of systems that are very traumatizing just by themselves. So if we're thinking about providing trauma-informed care, I guess the one question is why? And one way to answer that is look at the risk of missing the fact that someone has suffered trauma. What do we miss by not recognizing that? And we really know that there are lots of opportunities or touch points, if we can recognize it, to get people into the right care, trauma-informed care. And if we don't think of, and you'll see this in a minute, but if we don't think of it as almost a standard thing to ask about trauma, a routine to teach organizations to screen for trauma, then we miss this opportunity to get people into appropriate care. One of the things that we have looked at in the treatment community is the average number of therapists people have before they get diagnosed with a trauma disorder. How many therapists would you guess would be the average before people actually get diagnosed with one of the disorders we looked at?
4.
And it's close to 5, it could be between 5 and 7. Different therapists where they've gone into, maybe stayed a little while, maybe stayed a long time, but the trauma, the impact of trauma was never addressed. That's a lot of therapy, there are a lot of therapists. This can help recognizing those reactions and operating that way to routinely refer people can help a lot. The other thing is, there are things we can do as just part of the normal course of trying to help somebody or the normal course of interacting with their agency that can be re-traumatizing. What are some examples you've seen of that? Just unintentionally, we reactivate something.
I mean, I had an incident the other day where I work the front desk here, and I answered the phone with Mental Health Association of Maryland. This is Mary. And I was calling a random vendor for something completely unrelated to what we do, and he completely panicked on the phone just by me saying that I was calling from a mental health agency. And I had to reassure him that, like, no, we were just looking for this service, and it had nothing to do with what we actually do here. And so I felt terrible after the fact that for 20 seconds, this poor guy probably thought, something was going on.
That's a great example. Think about, one area this gets looked at a lot is inpatient care. Think about the things that when somebody goes into a hospital, just the normal routine things that could be potentially re-triggering. Right?
Taking things away from the person, making a bunch of rules.
Absolutely. Searches.
And sharing bathrooms, having your privacy, that's a real problem in inpatient settings.
Having your belongings searched, having somebody go through your suitcase, having your clothes searched. Things that are for safety reasons that are just a normal part and parcel of what hospitals do can be incredibly triggering and traumatizing. Even when the staff are sensitized to it, it can be, but at least if they're sensitized to it, there are ways to do it, ways to talk about it that reduce that risk. But some things inherently, just certain rules. I mean, the fact that some psychiatric units are locked, just that little thing alone is not a little thing, it's huge for somebody who's been traumatized in certain ways. So part of being trauma-informed is validating that these things can be very harmful, even unintentional. That's a difference. That's a mindset shift from the way some places are doing things. So one of the things that's really key is that trauma-informed care builds on the client's strengths. It's a shift in the direction of helping the client have a sense of control and empowerment over the interactions with us, over the interactions with our agencies. Does that, it's a shift as opposed to you come in and you comply with our ways of doing things, or it's that shift in being focused on the client and most importantly, focused on collaboration with the client. This comes from SAMHSA. They talk about the 4 R's of trauma-informed care approach. So one is what we've been talking about, realizing the widespread impact of trauma and what are the different pathways that can lead to recovery, recognizing, which is what we've been talking about in terms of the signs, symptoms. And that includes other people who are providing the care, the vicarious trauma symptoms, all of us who are helping. And this is the response can be fully integrating that knowledge into what we do, our procedures and practices, but also into our policies, like you mentioned. And then the bottom one is the one that I think when you get sort of a boots on the ground approach, doing things to prevent the re-traumatization is a big part of this in some settings. Not in all, but in some settings. It's really seeking to undo a long history of the way things have been done. Does that make sense? There's all of you know, there's a federal initiative to reduce the rate of seclusion and restraint in inpatient units to 0. That would be an example of an effort to provide trauma-informed care. And it works. It works. But if you think of something like restraints and seclusion, I don't think it takes more than 2 seconds to realize how traumatizing it would be for any of us, and if you have a history of trauma, re-traumatizing, right? And yet it's something that there are alternatives to, at least in a lot of situations, alternatives that work. And so making a commitment as a hospital, for example, to move in that direction is a part of taking a trauma-informed approach. And there's a big mindset shift in the treatment community from what's wrong with you, which is the diagnostic model. Remember I said I was going to bust a balloon? Sorry, DSM. And I'm not just bitter because they didn't invite me to the party. No, I'm not. But I mean, this is an important shift. To the focus on what's happened to you and how are you coping with it? How have you adapted to it? How are you managing the impact of what's happened? And that's a big shift in some ways of being, for some of us who've been trained another way, that's a big shift. Other people are trained this way from the beginning, and it's wonderful. Absolutely, but moving in that direction. And again, this comes from SAMHSA as well. So it's a strength-based approach. It focuses on the client's choice and empowerment of how they get care, what kind of care, what are the circumstances under which they get it. All those different areas of choice that a client can have, and looking at our policies and procedures that unnecessarily limit client options or choices. Right? There's some things that obviously there's not a choice about. If I go into a store and I want to buy something, they don't have it, they don't have it. That's not this. This is looking at what can we change that, and the joke is when you do trauma-informed care training, you go around and you listen to people and you say, well, what's an example of a policy here, like that, and they give a policy, and you say, okay, why is that in place? And nobody can remember. It was put in place so long ago, nobody knows why that policy is in place. And you look at it and you say, well, could it be this way? Well, sure. That'd be great, but it's just because we haven't looked at it. So the commitment to trauma-informed care is to review everything that you can with that in mind, choice and empowerment. We also emphasize safety, which gets into the treatment models where safety is a primary goal for a lot of people. And it's training everybody, and this is also a difference that some places have done, but not all. The trauma awareness training is for anyone who comes in contact with a trauma survivor. It is not a clinical enterprise alone, right? That this is everybody. Everybody who makes a phone call, everybody who answers a phone, everybody who says hi to somebody in the hallway gets trauma training. That's what a trauma-informed approach ultimately would move toward. You know, and the goal is greater chance of a positive income from any interaction with somebody who suffered trauma. So, shifting just a little bit to the broader organizational picture, we can think of these concepts as part of a journey forward. And when you look at organizations that have made this transformation, starts with being trauma aware. You're building an initial awareness, and we're going to dive a little bit deeper into that in just a sec. Actually, let's dive a little bit deeper into it right now. Can't see that slide at the bottom, but if you think of it as a progression to trauma aware, to trauma sensitive, to responsive, to trauma informed, let's talk about what are some of the components of that. So number one is training people to, and usually there's one or two people in an organization that start the process, to be aware that, hey, we don't do this, or we don't do it so well. Right? So somebody in that organization becomes the champion, in a sense, and develops, you know, a way of thinking about this that draws other people into a commitment to move forward, which leads to some initial training, foundational knowledge, doing a readiness assessment of, hey, are we ready to make these changes, right? And what are the reasons they might not be ready? Well, we're in the middle of hiring a new director. We don't have a director right now, so we can't jump into something like this, or, you know, but our budget just got cut. We have no money at all for this, and we've got to be creative. Lots of reasons that at any point in time, it may not be the right time. That doesn't mean you can't do anything. It just means for a full commitment. And then you start looking at how are we going to make the change? What are our internal processes? What are our resources internally that we can move us along? Being trauma responsive is really making that commitment and looking at all of those policies and procedures, which usually means getting groups of people, work groups together, task force, having a couple of champions, not just one person to get it started. People who are willing to do the research on what exists in trauma-informed care, how you're going to apply it to it, create a plan, and then all of this implies buy-in from a particular group of people, and who's the group of people that really needs to support this if it's going to work. Yeah, the people you're serving have to be a part of the process. And when you get to the level of gathering information, creating plans, if you don't have trauma survivors in your group, consider it. It's really important to bring survivors' perspectives to people, survivors who know your organization, who know what you do. Bring that perspective in. It involves a lot of training, and then implementing and monitoring the changes that are based on that training. So, okay, we're going to greet people differently. We're going to change this policy to this. Now we're going to monitor how well our staff are doing with that new thing that we're trying, that new policy. And you go through a process of continual evaluation and improvement, which takes a lot of energy and a lot of time. That's why a lot of organizations have a hard time navigating through this in any kind of short period. It's a longer term thing. And then as you monitor what you've put in place, you continue to change policies and practice to improve, to try things differently, to be more creative in the way you serve trauma survivors. So the good news is there's blueprints for this. There are guides for doing this. There are checklists. There's a lot of work that's been done. You don't have to do this alone or reinvent the wheel. But it's really important to have a couple of things in place first, and one is that survivor input. The other is commitment from the top down. If we don't have that, chances are other priorities will kind of sneak in, and that's hard to do. And we got to remember that we're doing this at the same time we're probably improving 20 other things in an organization, right? There's all kinds of initiatives. So you have to keep the time frames and the goals doable. right, for your organization. And whether that's large, small, I mean, you can do this in a very stepwise way. It doesn't have to be this massive transformation, with the end point being down here at some point in time. What resources you have to devote to it. You know, the resources, I mean, to train everybody, you know, all of you took 2 hours out of your day to be here. I'm sure you had other things you could have done 2 hours on Thanksgiving week, right? Besides being here, but you took the time. That's a commitment of resources. That's a commitment of heart. That's a commitment of energy and time. And to do that over and over again to get to that point can be a lot of work, and it's good work, and it's definitely worthy work. So thoughts about just that movement from, you know, thinking about this to then implementing changes in policies and practice and learning new skills and new ways of interacting.
It's important.
How many people would agree it's important?
I think anyone who, becomes a parent, it should be part of, like, I mean, even if you don't become a parent, you're always gonna be around kids, or you have your animals or something,
And what's great is that different organizations, you have to filter all of this through your mission. What is your organization's mission, right? So some organizations, their entire mission, you guys could be, we are gonna offer parenting classes to help try to reduce the negative impact. That could be some organization's entire mission. Isn't that awesome? Isn't that a huge contribution? So it's not like we have to do everything, but it's what's your mission? How can we make that mission more trauma-informed? That's awesome.
I feel like I'm gonna open a can of worms, but I don't feel like I work in a trauma-informed workplace to then be practicing trauma-informed, or not practicing, because we're not clinicians. But we go out and we talk to organizations with a lot of individuals who have experienced a lot of trauma. And so in some ways, feeling stuck between, I don't even know the words to describe it, but like I would like to know that we are thinking about becoming a place that is trauma-informed for the staff. I think that probably a lot of people who have experienced trauma are drawn to this kind of work. And that we need a workplace that is uniquely trauma-informed.
And that's a great point, and truthfully, under the board's leadership and recognition, and with Linda, who wishes she could be here today, but is on vacation, there's a deep sense of commitment for doing that, and this really is our first step, our foray into being trauma-informed at the personal level within the organization, and then thinking about how we're able to respond within the community. And Carrie, I thought, had a brilliant idea. Maybe a very simple step is every PowerPoint presentation that we give in the community, we have one uniform slide that we slip in that raises awareness and then points to, here's a resource. It doesn't have to be opening this huge can of worms, but just something as simple as that creates a ripple effect and a shift as we go out into the community. So I think that can be a starting point. So thank you, Kim.
Yeah, I mean, it does seem overwhelming when you talk about systems change in such a big way. And I've been thinking, as you were talking about some of the earlier slides, and I know Sharon's aware of this too, many of us in the local jurisdictions work closely with our police departments around educating around mental health issues and stuff. And I can remember in Howard County, whenever we did our trainings and brought the police and the consumers, we always took them to their own. And of course, the thing that always came up was putting us in handcuffs when they have to take us to the hospital for EPs. And that was always an issue. It was very traumatizing, and the consumers were very clear to make that to the police, who were clueless. It was a safety issue for them, it was their policy, etc. But over time, they learned how at least to explain when they had to take someone in handcuffs for an emergency petition, why they had to do it, how they had to do it, and they became much more sensitized to the consumer's response to it. And that made all the difference in the world over time. So I only add that because sometimes little things like that can make a big difference. It doesn't have to be the whole enchilada, so to speak. Sometimes just little pieces like that make a change. But your point is, that you made earlier, the victim or the consumer, or however you want to frame that, has to be part of that conversation. Because otherwise the police, it was over their head what was going on. So I think, again, the more we can bring survivors into the conversation, little things like that can have a real impact over time.
I personally like to take this to our faith-based organizations that are very disconnected when it comes to either mental health training, but just having them train on this trauma-informed care will be very important. As a matter of fact, last couple of weeks ago, I had a faith-based organization, different faiths training for first aid, mental first aid, and their beliefs are their beliefs, so exposing or trying to train them on these different processes would really, really, really maybe bring them back to understand that, each one is unique, the experiences they've gone through. But how do we marry your faith and then the interventionals that are available to help the victims?
Victor, where can we find this model to help us kind of shape our efforts? And then I'm also curious about resources that you might share with us for wanting to learn more.
Absolutely, there's tons. This is Trauma Informed Care Oregon. This is the model they put together. SAMHSA has a lot of great stuff I can send to you guys. And there's also, there's lots of different organization-specific things. So if you're a mental health organization, there's training, trauma-informed care training now for training people who are treating the elderly, taking care of the elderly in nursing homes. How does trauma reactions express themselves in people who are starting to have dementias? What does that look like and how do you take care? So it just depends on what you're looking for, but I'd be glad to send you a ton of stuff.
Great.
The National Council also has some really good stuff. We did a year-long, really, I guess, for a year they worked with our organization, and this was 6 years ago maybe now, and you're right, this is an ongoing thing. You never stop changing your policies, looking at things, and then when you start in, and it's not easy, and it really is, you're right about getting the consumers involved, and then also it's got to start from the top and go down. And every month and every staff meeting we talk about it. And if we don't for 1 month, we feel like, we've left something out. So,
Right.
But they have really good programs as well, or you can work with them.
Victor, are you going to be able to share the slides?
Sure. Absolutely.
Okay.
I'll send it to Sharon and Sharon will figure out how to do that.
So are we not phase one? Right?
Or phase one.
Is that where you're at?
Good job.
Keep done.
Well, thank you all. Is there anything you want to say before?
Any questions, comments? Victor, thank you. So Victor is going to come back and work with a team. If you're interested in joining the work group to begin to explore how do we keep working on phase 1.1. What does that look like, and map it out so that what would it look like for our organization across this tool to be responsive in the community. So we welcome your input. And Carrie and Kate, any thoughts or comments?
I think I'm just very excited to get these slides and really take a close look at that, and I think begin to work with that work group and put together some information for our staff and committee and board. And thank you to all of our board members who were able to attend today.
And then,
Yes, and I think, this would be great because we all serve different communities, populations. Mine is very diverse, being Montgomery County and Prince George's County. So everything we talked about is there. So it would be great to be part of the committee and see how we can put this all together.
Thank you. Thank you.
That's the one.
Not the first one.
Not the first one. Get up again.
Yeah.